Hello, everyone. My name is Shadi Reyes. I'm the co-host for this activity. I'm really privileged to be with esteemed speakers for this webinar. This is a series of webinars that DMC have put together to increase awareness of cardiovascular disease in the community for education, as well as to offer services to referring physician and as a showcase for what we do at DMC. With that, I would like to start with the introduction of our speakers. Is Dr. Cantizara. He is the Director of Cardiovascular Service Line at Detroit Medical Center. He is a cardiothoracic surgeon with a phenomenal career in cardiovascular surgery, starting from Mayo Clinic to UPMC, Hopkins, and Texas, and eventually he is here at DMC. We're really delighted to have him and have his experience that serves a lot of patients in our community. My second speaker is going to be Dr. Yusuke Terasaki. He is a cardiothoracic surgeon. He's also a graduate from Johns Hopkins University in cardiovascular and thoracic surgery. With that, I would like to start with Dr. Zahar, and the agenda for today going to be as follows. Dr. Zahar going to talk about the role of advanced heart care providers in pandemic. This is a hot topic right now, especially we are dealing with COVID-19 and how much impact it did have on our career as physician and our patients in the community as well. Second topic going to be by Dr. Terasaki about safe cardiovascular procedure in COVID-19 era. He's going to highlight a specific aspect related to ORs and beyond. And I will end up with a short talk about the management of COVID-19 and acute coronary syndrome. For the question, this is an engaging and interactive session. So if you have any question, please drop it in the comments. You'll have the opportunity to ask the speakers as well as any question related to COVID-19 and heart disease. With that, I would like to start with Dr. Cantizara. Dr. Zahar, can you please share your screen?
As I was saying, I'm going to make some broad strokes about what I believe my observations about what the role of an advanced healthcare provider can be during this pandemic. We face natural catastrophes on a regular basis that have a huge toll on human life. Tsunamis, earthquakes, tornadoes, hurricanes, nuclear disasters, volcanic eruptions, and climate change. When these things usually happen, we look to experts for their guidance as to their opinions and as to what the science is of these catastrophes. So here we find ourselves as of February. We were slammed by a viral pandemic that primarily affected our patients personally. These are the elderly, the obese, hypertensive patients, diabetics, patients with renal failure, patients with chronic obstructive pulmonary disease, and patients with cardiac disease. So my first observations were when everything was going haywire was that we had to instill the sense that our service line was going to be stable. This started with the office staff. We needed to maintain call schedules when people were out from work, and we needed to maintain a steady service coverage. That included diagnostic procedural reliability for coronary angiography and for non-invasive diagnostics. We had a lot of people out. The hospitals were losing money. People were on furlough. But despite all this, we had to maintain our steady diagnostic procedural reliability. And remember that cardiovascular disease, the death tolls in the United States on an average day is 1,700 patients per day. That disease process does not stop during a pandemic. The urgent and emergent procedures need to be taken care of. This includes patients for ST elevation myocardial infarction therapy and the surgical emergencies like acute coronary syndromes and patients with aortic dissections. So how can a cardiothoracic surgeon help in all of this? Well, first off, we have to model the consensus behaviors and protocols that hold up to science. And importantly, we also have to work to change the protocols that don't make any sense. People look to us to provide solutions, and we need to be proactive and not reactive. There were physicians that basically ran with fear from this virus and effectively took a month off, and there were other physicians who looked around and said, how can we be proactive in this pandemic? I'm going to give a few examples. Patients that require prolonged intervention often require tracheostomy for comfort, for mouth care, for pulmonary toilet and bronchoscopy and enteral nutrition via gastrostomy. And my team observed that in these COVID units, no one was stepping up to offer this service. So we met with the leaders of the medical intensive care units and our makeshift COVID units and said, we're skilled in this particular type of procedure, and our service became the trach peg service throughout the hospital system. And we also were asked then to help write a common sense policy that protected the healthcare workers and provided this comfort for our patients. And this is our trach peg team enjoying a coffee while they're social distancing after having performed such a procedure. The other thing is that I noticed was that we needed more, moral support, and morale was very important. And so I encourage our hospital is directly off the walkway from the parking garage, and it's the access point of many of the employees into the hospital system to come to work. And so we organized this poster board that was right when you come in off the walkway, which detailed what we were doing as a service line in terms of the entire hospital system for these COVID positive patients. You see here, there's a daily sense of the patients that are off the ventilators, patients that were discharged the day before, and then the total number of patients that were COVID positive that were treated in our system and had successful discharges to home. And this was the very first procedure, or the very first poster which was posted. You see now here 832. Several months later, we see this number became 3,340. We turned our entire hospital patient beds over several times with COVID positive patients, and these are all alive patients that are home. This did a great deal for supporting the morale of the workers. Now, we need to learn from these pandemics, and those of us who are been in medicine quite some time remember that we've also lived through a pandemic in the past. In 2009, we had the H1n1 pandemic, and the CDC estimated that somewhere between 150,000 and 500,000 people worldwide died because of this. Interestingly enough, this particular pandemic struck the young, and 80% of these deaths were estimated in patients who were younger than the age of 65. Now, we're not old enough to remember the 1918 H1n1 pandemic, which they called the Spanish flu, but that killed 1 to 3% of the world's population. The 1968 H3N2 was only 0.3, and then the H1N1, which I recall very vividly, that was 0.001 to 0.007 of the world's population. So not nearly so bad. But I'm going to have a few slides here to show a little bit how cardiothoracic surgery learned from this pandemic in 2009. In 2008, there was a randomized prospective trial called the CAESAR trial in England, where there were 180 patients from 68 centers with adult respiratory distress syndrome, which were randomized to a therapy which I'll present in the next couple slides called ECMO, which stands for extracorporeal membrane oxygenation. It's effectively a heart-lung machine at the bedside that supports the heart and the lungs while those organs recover. And suffice it to say, this was the first study in a randomized way that showed that out of every 6 patients that were treated, there was 1 extra survivor in the ECMO group compared to the patients that had conventional ventilation. And so this showed that this ECMO therapy for patients that would otherwise have likely died on conventional ventilation worked for patients that had their lungs horribly affected from a process such as a virus. Now, this Anz Ecmo Trial stands for Australia, New Zealand, and this was a trial that came on the heels of the CAESAR trial, where they took 68 patients which had H1N1 flu, or they were suspected they were, and they put them all on ECMO at centers that specialized in this type of therapy. And of those patients, they only had a 21% mortality, so that at 80% survival, and they proved that that this therapy worked for an acute viral illness which caused adult respiratory distress syndrome. Now, this study has also been repeated more modernly. This is a study published in the New England Journal in 2018. It's also a randomized trial looking at ECMO therapy for patients that are affected similarly to the COVID virus. And again, they showed very similar results to the Caesar trial in the modern era, where they had approximately a 10% difference in survival in patients that were randomized to be supported by an artificial lung as compared to those that were supported by a ventilator. So this is what an ECMO pump circuit looks like. You have a pump head here, and you have a centrifugally designed 30 cc priming volume pump, which pumps, it can pump to replace the support of the heart, and you can cut an oxygenator in it, so you effectively have an artificial heart-lung machine. This is what the console looks like that when you put it on at the patient's bedside. Now, how does we came late to the game in terms of getting involved in supporting COVID-19 patients with ECMO, but cardiothoracic surgeons in Chicago, in Rush and in Christ's Hospital in Chicago, have a remarkable series of treating patients with COVID-19 with this ECMO support. They did 40 patients between February and the end of April. And as you see here, these patients were intubated for 4 days prior to going on ECMO. Then they had 13 days on ECMO before they got extubated and mobilized. And the total ECMO run here is about 30 days, 29.9 days. Remarkably, 80% survival. Now, this comes at an enormous cost to the institution in terms of human work power and in terms of time. You see here, this block of time is the time that the patient spent in the ICU, and this entire block of time is the times that they spent in the hospital. And this goes out months at a time. So these hospitalizations were well over a month, but at the end of the day, out of 40 patients put on ECMO, they only had 6 mortalities. It's a remarkable series where cardiothoracic surgeons raised their game and stepped in and supported young patients that otherwise would have died on conventional management. Now, I'm going to present a series of slides to show what I really think the advanced care providers are responsible for. We're responsible to provide a coherent and a thoughtfully adjusted, fact-based, common sense advice to our administrators, our medical staff, our community, our friends, and our family. If you watch the news these days, there are plenty of opinions, and I believe we have enough opinions, and we need to rely on facts. So how does an advanced practitioner do that? Well, there is a lot of continuing medical education which is available to us on COVID-19. And in terms of my personal education, I looked to what I see as 3 of the thought-leading manuscript producers: Nature, Lancet, and the New England Journal of Medicine. Nature publishes an ongoing abstraction of major COVID-19 papers since March of 2020, and they abstract all these papers as they come out. Lancet has a specific COVID-19 website with manuscripts in a section, and there's a section in the manuscripts which detail what the relevancy of the study is to this particular pandemic. And the New England Journal specifically decided that they were going to rapidly disseminate advice and up-to-date revelations, and they have a specific free download COVID-19 website. And I'm going to detail a few things that I think are important, what I mean by adjusting how we do things and modeling fact-based behaviors. From Kwok Young Yuen in Hong Kong, we learned that something more needs to be done than just a 14-day quarantine. We learned that virus sheds in patients that are positive from endotracheal aspirates and saliva all the way out to 30 days. There's a drop-off around 25 days. So patients who are infected actively can reinfect other people to an extended period of time. We've also learned that the affected organs are not just the lungs. The lungs and the pharynx have the highest viral loads, but we see high viral loads in kidney, liver, heart, brain, and in the blood. So all of these subspecialties have had to learn to deal with the manifestations of the virus in these organ systems. We've learned that masks are indeed effective. This is a study showing patients that had by nasal swab and throat swab were positive, and if they collected specimens without the mask and with the mask, we see with a mask the droplet spread effectively is zero in this particular study. And these studies are very important because you hear a lot of politicization of this topic, and we can look to science, we can look to Nature Medicine to give us articles as to how effective these maneuvers are. We've learned that physical distance is important. This is a study showing that the real physical distance is 1 meter. The drop off of spread is pretty dramatic from 0 to 1 meters, and from 1 to 2 you get additional benefit, but not as much as from 0 to 1. So the real distance is probably 1 meter, and this is based on science and not just opinion. If you look at surgical face masks, you see that in a meta-analysis looking at all the studies over the last pandemics related to flu and related to COVID, these are just studies related to COVID. You see here a dozen studies, every single study confirms that wearing a mask is effective in preventing the spread of this virus. We've learned that social distancing and adherence to rules actually have worked. This is on the bottom here we see what the timeline was, and I'm not going to dwell on that. I'm just going to point out here that this is all of Hong Kong, which those of you who have visited know that it's a huge bustling city. We see here the total numbers per day of patients were 30 and 40, and not like in the United States where it was into the 50,000 range. So Hong Kong was very effective and in this particular study on a survey that was associated with it, 95% of patients were compliant with face masks and 85% were compliant with social distancing and limiting social gatherings. The same thing happened in New Zealand. New Zealand effectively eliminated transmission of the virus by measures, and again, we see here on the left-hand column, the maximal numbers of positive people per day were in the 70s and 80s and not in the 1,000 range. And here we see no new cases for several months on end. And then the alert levels were decreased accordingly with the lack of transmission. Now, the other thing that we see in the news a lot is about how are social gatherings affected. This is a very interesting study that came out of Washington that was released by the CDC. And this was a choir practice for 2.5 hours in a church choir where there was one patient affected. And as a result of this choir, all these people in yellow were COVID positive. And only 8 people were not affected, did not get the virus. Of this group, 2 people died. So this was, I would say, a very hazardous church choir practice. And indeed, it gave us lessons as to what we should do in terms of our own behavior. Now, I'm going to talk just a couple more slides, just looking at that there is data to suggest that some of the therapies that have been suggested and have been initiated do work and some don't work. It is definitely true that convalescent plasma has an effect on the human body that's affected with a virus. There's a small study published in JAMA back in March, soon after the virus took hold. And this is a study looking at titers of interleukin-6, which is an inflammatory mediator, and 5 patients that received convalescent plasma. And you see every single patient, their interleukin-6 dropped precipitously during the post-transfusion day period. We also have evidence that antibodies do protect, and developing a vaccine is important. This is an interesting study where it was effectively a ship that served as a petri dish for the virus. Everyone was tested before going on the ship. And out of 126 sailors, nearly all of them became positive with the virus. And the most important point of this was the first study that showed there were 3 people who had antibodies going onto the ship. They had been positive and had cleared the virus before. And all 3 of those patients in dark blue did not get reinfected with the virus. So their antibodies protected them from an infection, from a reinfection. We also find out that it's interesting that some members in our population are probably immune to this virus. This is a study that was published in Nature in July showing that in patients that got infected, 83% developed a CD4 T cell reactivity and effectively developed T cells that were reacted to the virus and helped them to clear it. But importantly, the control arm of 35 healthy donors that did not have the virus also had these protective T cells, which is likely why some people, maybe a third of our population that's exposed to this virus, will not get it. And some of the therapies have been shown to have no effect whatsoever, but some therapies do. This is a meta-analysis looking at steroid use, systemic steroids. There are 7 studies, and all but there were 7 studies, and nearly all of them showed that there was some protection by steroid use. And this now has become part and parcel of our therapeutic package that we give to the patients. Virtually all the other therapies that you've heard about in the news have been non-effective. And there is hope. This is September 2nd, phase 1 to 2 trial of spike protein vaccine done in the United States with 26 volunteers, all of which developed neutralizing antibody to this vaccine. We've also within the last week, I don't have a slide about it, but we're also aware because of the Lancet publication from the Russian vaccine that the 76 people that were given that vaccine that were volunteers, all of them developed strong antibody with immunoreactivity against the virus. So I'd like to say that this is what I believe our role is. Our role is to stay current, to stay relevant, and to keep ourselves and the people we care about safe. Thank you very much.
Dr. Zera, thank you so much for a very thorough presentation going over options for patients as well as what is the current recommendation for COVID-19. A few questions that were raised is related to the fear of patient coming to the hospital due to they don't want to be infected, and especially for elective procedure. Is it a heart valve? Is it a bypass surgery, cath, echo, whatever it is related to the heart? There is some fear in the community from the getting infected coming to a healthcare institution. What is your strategy and protocol right now that's implemented at DMC Heart and Vascular for these patients?
I'm going to table that question until after Yusuke's presentation because he's going to address some of those issues. And I think we should save that one till the end. But suffice it to say, I would say that those of us in leadership positions have a fairly sophisticated look at this virus. And I think we've been careful in the right ways to protect our patients. And I think we should save that till the end so we can legitimately talk about what we're doing to ensure safety for our patients.
Sure. So another question related to the ECMO patient from Christ and the hospital from Chicago. My question was, so you have 40 patients, mortality was very low. So what are the triggers to cannulate these patients for ECMO? Are we doing it too late in other places, or did they do it too early, or they are not doing it in enough sick patients? What's your take on that?
I think my take is that most of the patients, there was a reluctance early on to place these patients on ECMO. They're not ideal candidates. Many of them are overweight. They're very heavy. They're difficult to oxygenate. The organs infected consume a lot of oxygen. and we've had a lot of difficulty oxygenating. And there was the cardiothoracic community was very reluctant to use ECMO early on because we had a lot of early failures and mortalities, and it is a very energy and money consuming venture to place these patients on ECMO. I think that what we need to do when we see a paper like this come out where they're very, very positive is we need to get direct feedback about how they're doing things. It's very clear that the patients that we put on came to us very late. They had been ventilated for much longer than the 4 days that were done in Chicago. So I think that's the very first thing is for the hospital systems to be aware of who offers this therapy and to get the patients referred early to the experts that know about providing this therapy to the patients.
That's really, I mean, kind of describe it mainly now. And as you said, it's kind of utilize a lot of resources from the hospital for COVID patient, not just cannulating the patient, but I think a lot of work happened after that.
And
so the selection is very key.
And this was so valuable to our program in the other way is getting our people trained up. And in the midst of this pandemic, we had an electrocuted young man who was 18 who survived and walked out of the hospital totally normal after 3 rounds of chest compressions. And we had a drug overdose with an aspiration who survived. We had a young lady with adenovirus, not coronavirus, that survived on ECMO during this period. We had another person who had COVID positive antibodies. We're not sure what his lung injury was, but he survived to discharge. So we had, during the midst of this COVID epidemic or pandemic, we had quite a few survivors of our ECMO program, which bolstered morale for the program.
Absolutely. And because, as you said, there is the heart attacks, the shocks, the cardiac arrest, they're not going to stop with or without COVID. So selection of these patients and how to gear your strategy to cannulate or when is very important. All right. Thank you so much, Dr. Zer, for this very thoughtful presentation. With that, we'll move on to Dr. Yusuke Terasaki to talk about safe cardiovascular procedure in the COVID-19 era. I just want to give a highlight that Dr. Terasaki is going to be talking about how you can safely perform procedures during COVID-19, how you can come to the hospital and get your procedure done safely in a very secure COVID-free environment, especially for COVID negative patients. He's been working on this along with our anesthesia team, our operation team, to make sure the transition of care and throughput is very well done. I will be also talking after that about how we manage acute coronary syndrome in the cath lab. It's going to be a very brief talk. So, but meanwhile, if you have any question, please use the chat box or the Q&A box at the bottom of your screen or your phone to drop any questions for the speakers, Dr. Zer, Terasaki, or myself. Anything related to cardiovascular care and COVID-19 or any question related to how you can perform these procedures safely, or even what is the current policy for performing procedure in Michigan or in the Medical Center. Also, I'd like to highlight one of the points that was brought up by Dr. Zer about the vaccine and early trials and publication in the Lancet Journal. It's, as you see, there's a lot of work still required. It's very early phases. It's baby steps. So precaution and prevention is the key at this point of the social distancing, the face mask, especially when you are going to public area, is very important. As he showed nicely in multiple references, that face mask is very important during that period. And that's what we practice in the hospital as providers. And we have stations where we wash hands between each patient, either it's inpatient or outpatient, before we go to the next room. So something has been acquired from different healthcare systems as well, but we're learning more about it. But now with the flu season coming up, you have to be extra careful because any fever or sore throat can be beyond COVID, can be the regular flu, but still kind of the same precautions applicable, which is a win-win situation.
Yeah, Chowdy, I think it's pretty clear from the literature that it's safe to go about normal human activity. No problems at all. the problems exist in closed spaces when people are very close proximity. And like in the choir study, everyone was singing at the top of their lungs for 2.5 hours, all crammed together in church pews. And so these are the things that just common sense says these are the things that we should avoid.
All right, we're having some technical difficulties here, but I think we're online. Can you hear me?
Yes, perfect. Thank you so much. Go ahead.
And you can see my screen now.
Absolutely, yes. Perfect.
Okay. All right. So I wanted to kind of start off with a personal anecdote because I was one of the, I guess, unfortunate ones who came down with COVID earlier in March. So the last week of March, I began having this profound fatigue, so much so that I was having difficulty getting out of bed and getting to the bathroom, which is right next to the bedroom. I had diarrhea for a couple of days, and I've never experienced any headaches in my life until this time when I started having these recurrent headaches, intermittently actually for over 3 months or so. And over just 2 months, I started not having headaches, but I've been having these headaches for a long time. However, unlike some of the other patients that showed up in the hospital, I actually did not have any respiratory symptoms. I was not having any coughs. I did not have any fevers. I did have a travel to Nashville in a large group environment, and my significant other that I live with also tested positive for COVID-19. But after a couple of days, all the symptoms resolved, and I felt better. I quarantined myself for a week, and then I went to work. Let me see if I can go to. So a month later, I started having this swelling in the back of the throat, and one day I woke up and I just could not breathe when I was laying flat. So I went straight to the emergency room here in Harper and got a CT scan. I was diagnosed with a peritonsillar abscess. This is actually the CT scan of my head, and you can see this abscess that's compressing my airway. And I had one of the ENT residents come over and emergently drain the abscess cavity that you can see on the right side of the picture. So I think there is definitely a lot of asymptomatic patients like myself, or very little symptom patients that, like myself, opened up later on. And anyways, I am one of many in Michigan who came down with COVID. As you can see in this picture, there's about 114,000. This is up to date up to yesterday. 114,000 patients here in Michigan, mostly located in the Detroit metro area, around Oakland, Macomb, Wayne counties. And this is the chart. So when I got sick, this was the end of March. So this is exactly when the surge happened earlier this year. And then there's the trend down. And then when the summer hit and everybody was going around their business, you can see that there was another slight surge towards the end of June. And it's been kind of plateauing down again thereafter. And as you can see from these graphs, you can see that this virus is disproportionately affecting people who are of older age, above 80, and of people of African American descent, as you can see in the graphs on the right. It's definitely affecting men and women equally. And this is some data from our hospital system. So from left to right, this is Children's, DRH, Harper, Sinai Grace, and Huron Valley. And you can see that there is a total of about 3,000 cases throughout the system, and about 700 cases in DRH, Sinai Grace, and Harper. But when you look at the next graph, these are the number of deaths from COVID that we saw in our hospital system. You can see that it has disproportionately affected Sinai Grace. Whether that's from racial inequality, I don't know for sure, but there's definitely some inequality here in terms of the number of deaths per cases that have been seen in our hospital system. And this is another pie graph showing the same thing. So purple here is the Sinai Grace number of cases as a proportion to the rest of the hospital system at DMC. And in terms of deaths, it actually encompasses almost half of it. So there's some inequality here that I don't quite understand why it is, but it has happened. And so when you see this kind of solemn data, you know, there's no wonder why a lot of patients would come up to you and ask you and be worried about coming to the hospital to be taken care of for other issues. Sorry, this is another data that's coming from our hospital system with the number of COVID cases in our different hospitals and number of patients requiring ventilator. And as you can see, if the patients go on mechanical ventilator, percent of the patients have passed away from that. So this is a really bad disease, especially for patients with respiratory symptoms who get really sick and who end up on breathing machines. And no wonder why, you know, our patients are asking, you know, should they be coming to the hospital? You know, should they be worried if they have an elective case that is coming up? You know, should they wait? So let's look at, you know, this is specifically to cardiac surgery now at the DMC. We have performed a total of 133 cases since COVID hit up to now. And of those 133 cases that we have performed, only 3 patients were diagnosed with COVID-19 post-operatively. 2 came towards the end of March or mid-March when we didn't really know too much about COVID at that time. And 1 came later during that second surge in the summer in August. All 3 patients are now discharged. There were no mortalities, these patients who were diagnosed post-operatively. We did see 2 asymptomatic COVID positive patients preoperatively. And for these patients, since you know, they were completely asymptomatic from the COVID, and they were, you know, they had very little symptoms from their cardiac issues as well, we actually sent them home for a couple of weeks, and then they came back with a negative COVID result before we proceeded to performing elective procedures on these patients. So there are very few people, you know, since COVID hit amongst our patient population who ended up having COVID positive. So what are the ways that we are, you know, doing in the OR and the ICU to prevent, you know, our patients from contracting this virus? Well, number one, in the preoperative environment, all the patients have to have a negative COVID test within 72 hours of surgery. So whether they go to their own, you know, closest hospital or clinic, or they can come to our hospital to get tested, they have to all have a negative test before we can proceed to surgery. Obviously, some of these patients have difficulty going to another clinic or a hospital because of transportation issues. So these patients can actually come to our preoperative area, and we can do a rapid PCR test on these patients that will result within an hour. And if it's negative, then we can proceed to surgery. Now, in terms of the OR, we have decided in the hospital system that non-aerosolizing procedures can be performed in a normal pressure room as opposed to a negative pressure room. We did have, during the peak season of COVID, 2 negative pressure rooms in Harper OR for performing aerosolized procedures such as tracheostomies. However, I had spoken to the OR team yesterday, and they had actually since then gotten rid of the negative pressure rooms since we had so few patients with COVID positivity in the OR. And all the staff must don proper PPE, face shields, including an N95 mask when they are involved in any cases with COVID patients. So I think Dr. Zaire had touched a little bit about tracheostomies, but you know, we did perform these procedures. Tracheostomy is basically a procedure where we perform on patients who end up on breathing machines. The long tube that we have placed on these patients are high risk for infection later on. So we try to place these patients what's called tracheostomy tubes, which are these tubes that go directly into the airway through the neck to prevent that risk of infection. And traditionally, this is performed in an open fashion, where they go to the OR, and they can large incision in the neck, dissect down to the airway, and put this tube in. But over the last decade or so, there's been a new technique called a percutaneous tracheostomy tube placement, which we decided was probably less aerosolizing than performing an open tracheostomy approach. And that's the method that we've been using to perform tracheostomies on our patients. And across the hospital system, we've performed about 44 tracheostomies. And in Harper itself, I think we performed about 20, and majority of those, our team, the cardiac surgery team, performed the tracheostomies on. And we had preferred to do these at the bedside, since these are really quick procedures. As long as we have the dedicated team to perform these procedures, it's a really simple procedure. And so we decided to perform these procedures within the ICU units instead of bringing the patients over to the OR, even though there was a negative pressure OR rooms in the OR. We decided that it's probably safest to actually perform these patients, these procedures in the ICU, which would prevent them from having to transport the patients through clean areas of the hospital, through the elevator shaft, exposing, healthy asymptomatic patients from the virus. And in terms of the procedure, we perform it percutaneously using cell denture technique and dilatation to minimize aerosolization, as we talked about. And again, we perform this by a dedicated team, simply consisting of a surgeon, an assistant, and an anesthesiologist, all wearing and donning appropriate PPEs. And here is a picture of one of our dedicated anesthesiologists wearing the appropriate PPE during our tracheostomy placements. And on the right is a depiction of how the percutaneous tracheostomy is performed. And as you can see, it's really just a needle through the airway, so there's really no concern for droplets escaping this area.
Yusuke, just for the sake of time, you have a couple of minutes.
Sure. Okay. All right. So in the ICU, all the COVID patients are placed in COVID units or in isolated ICU rooms. The nurses and all the staff are using face shields, N95s, and gowns. I'm going to show you a picture of this as well, but the IV poles that are hooked up to the patients are actually located outside of the ICU door to prevent unnecessary entry and exit of staff into the rooms. And ICU staff, whenever we perform these tracheostomies, remain outside to prevent any contraction of the virus. And Dr. Zera mentioned about the ECMO, so I'm not going to talk about that too much. And this is a photograph of one of our COVID patients that we have right now. And as you can see, the patient is inside the ICU room, whereas the IV pole that's hooked up to the patient is actually outside, so that nurses can titrate the drip without having it. These are some of the ways that we're protecting the staff from the patients. And so what's the data? So we have 9 ICU care unit where the nursing staff see all our postoperative cardiac patients, and they're the ones who are also taking care of all our COVID ECMO patients. There's I think 40 nursing staff at the moment, and these patients are day in, day out, 24/7, interacting with these COVID patients, and only 3 actually contracted COVID-19. They're all asymptomatic and doing well. And amongst the floor staff, the step-down units, there were actually quite a bit more. Almost half of the nursing staff and the PCAs actually contracted COVID-19. We don't really know where that came from, but it's interesting to know. And then one of our people also tested positive for COVID-19 aside from myself. But again, back to with all these staff contracting COVID, only 3 tested positive for COVID-19, and this was early on in March when we really didn't know too much about this disease process. And I want to end with this photo of the cardiac surgery team going to get tested for COVID antibodies. Everybody was convinced that since they were around me pretty much every day in, day out, that they had contracted COVID-19 as well. And surprisingly, not a single one pictured here had PCR positive or antibodies. And they're the ones who've been really working with me day in, day out, throughout this COVID era. And so I think the learning point from this is that as long as you're wearing a mask and washing your hands and, wearing your protective PPEs, we are well protected, and as well as the patients, who are coming here to get their elective cases.
Thank you, Yusuke, so much for your presentation. Very thoughtful, especially sharing your personal experience and also your personal illness with us. That's very kind of brave, and also show a lot of how much we went through during that COVID peak. With that, just for the sake of time, I'm gonna share my slides and do my presentation. This very brief presentation about the management of patients with COVID-19 and acute coronary syndrome. Due to the technical difficulty we had, maybe we're going to go over time, like 10 minutes, to allow for your questions and also for discussion point as well. Again, this is my topic. As you know, the MI or myocardial injury in COVID-19 happen in 20 to 30% of COVID patients, and associated with increased risk for all-cause death. And this is with analyses we do what's called case fatality rate for COVID-19 remain low in 2.3%. However, in patient who has underlying heart disease can go as high as 10.5%, which is especially patient who had heart failure, valve problems, or blockage or coronary artery disease. So the mechanism for heart disease and COVID, either acute coronary syndrome due to plaque rupture, somebody has comorbidities, risk factor, smoker, hyperlipidemic, diabetic, or due to demand ischemia because of the stress that the body is going through. Microvascular ischemia also has been reported, include also an injury related to cytokine dysregulation and myocarditis. So as you know, as we came to know that this is more an inflammatory process, that's why there's an introduction for steroids, as well as the risk for steroids, as well as antibiotics and hydrochloroquines. But however, the most striking thing of the effect of this disease on us is the drop in the volume of patients coming to the hospital. It's not from the business perspective, it's more concerning from a public health issue. We have nationwide, as well as in Europe, they notice a decrease in weekly volume of patients presenting to the hospital with chest pain, as well as a drop in the volume. As you see on the right graph here, this is a weekly drop during the COVID-19 between the March and May, which is a significant decrease that can up to 40% that affects and also has been reported to have a side effects down the line. I will show you through data. So how did we start this problem? Back in April 2nd, I posted a tweet on Twitter that's showing that we have noticed a decrease in STEMI volume in our lab. And where are these people are going? Not just pains anymore. Where are they going? And as you see here, from 500 plus patients, there's a 50% drop in the volume in the cath lab and nationwide. And these are from international and national volume. So we send this tweet along with our observation to European Heart Journal to tell them, like, are you seeing the same thing? And they ask us to write a paper about why this drop, and also to complement a paper coming from Italy showing the same observation. This is the hypothesis list that we came up with, but mainly things that kind of keep staying on top is patients are fear of coming to the hospital. They don't want to come here. They don't want to be infected. Or if they are infected, they don't want to come to the hospital and infect others. Or because they lost their insurance and economic strain on them or their beloved one, they don't want to come and overstrain the stress. Same thing we observed, we submitted a survey across like 12 cath labs in Michigan, one in New York and one in Kansas, about do you see the same observation between March and April 2019 compared to 2020? And sure enough, there was a 46% drop in volume across the state here in Michigan. And we published this data with a concern that where are these patients are. We still have the same risk factor of smoking. As a matter of fact, people are more sedentary now than ever before because of the social distancing and home lockdown. And that's the consequence we're going to see. We're going to see more and more paper coming on late presenters. This is a case we published about patient coming as a young guy, 36-year-old. Late presenters have acute myocardial infarction in the LAD causing LV thrombus and acute decompensated heart failure. That was a kind of a consequence because he didn't come on time. So we wrote again multiple papers explaining about the pathology, how this happened, and what is the mechanism. But also we would like to highlight a few things related to biomarkers. Do we need to trust the troponin? Is it still applicable and during COVID positive patient? And yes, it is. It's a marker that there's a myocardial injury, there's a myocyte that's getting lost, and this is due to heart failure or myocytes or myocarditis. Similarly, the loss of either from inflammation or de novo plaque rupture during COVID infection, it caused ventricular arrhythmias, that VT or AFib was the main manifestation. And lastly, I'm going to do some comments on the medication. So how we manage these patients, and in our lab, and also some consensus from different labs and guidelines. So this is a paper coming from Sky suggesting what is the best practice for COVID-19, as well as Jack published a guideline for management of these patients, as well as Jack intervention suggesting how do we manage these patients and how we triage them to minimize the risk of infection, as well as minimizing risk of jeopardizing the staff who are coming to the hospital. So at Detroit Medical Center, this is the way we do it here, or this is what we have been doing, especially during the peak pandemic. Single procedure room that dedicated for these patients who are confirmed to be COVID positive, or PUI, or patient under investigation. Negative pressure room, as well as we practice PPE very stringently on these rooms as well, as this is a standard of care. Already Dr. Terasaki and Dr. Zahar mentioned it already and covered it extensively. And also for patient, we did not bring every patient to the cath lab who are troponin positive. There is a triaging system where we have the patient having a positive troponin due to what's called NSTEMI with no ST elevation. These patients can be managed medically, especially if the hemodynamic is stable, if the ST changes is not visible, or if they don't have any heart failure symptoms, or they are not in shock. These patients literally can be managed by anticoagulation, as well as a heart failure medication that's listed here with aspirin, P2Y12 inhibitor, statin, beta-blocker ACE inhibitor initiated early during the phase of the disease. These are algorithms suggested by the Societies of American College of Cardiology and Sky and American Heart Association, and how to identify these patients and put them in the cath lab, or try to put them in their locked room or quarantine, or bring them to the cath lab for urgency. As you see, the very high risk feature are somebody who has refractory chest pain, or somebody in shock, or life-threatening arrhythmia such as a VT or VF. For STEMI patients, a little bit different. As a matter of fact, there's some labs has been practicing thrombolytics in these patients who are stable, or people who has inferior infarction due to RCA infection. And then usually when this is patient completely healed from the infection, bring him back to the lab and do the angiogram to define the problem. So again, different practices, different suggestions, but we don't have enough evidence how the best way to treat these patients, but mainly prevention of spreading of the infection. The ACE inhibitor has been a debatable topic, but eventually there's multiple meta-analysis as well as single center analysis suggesting that there's no harm. As you know, there's a link between the ACE inhibitor and open the gate for the more spread or more infection. So if somebody was taking lisinopril, losartan, these medications don't increase the risk of infection. As a matter of fact, it causes more harm if you stop it on a heart failure patient. And similarly for other paper published as a meta-analysis from European Heart Journal. In terms of the safety and efficacy of hydroxychloroquine, which has been debatable for a while, we looked into meta-analysis, analyzing the data on what is the best practice and is this helpful or not. And because we have seen patients who are been on hydroxychloroquine, but they suffer from major arrhythmia. As you know, it's prolonged QT, it has a high risk for a VT and VF and sudden death. So, and sure enough, I mean, hydroxychloroquine offers no benefit in terms of decreasing the viral load. And you can see that on the first graph on the top compared to no therapy. And as a matter of fact, can increase the odds of mortality if you give it to patients who are COVID positive due to effect on cardiovascular system. So that kind of discouraged a lot of experts in the field to recommend routine use of hydroxychloroquine in these patients. And as a more effort to kind of spread the knowledge and also to explore the topic and learn more about it, there's a NACME, or National American COVID ST Elevation Myocardial Infarction Registry, which is Detroit Medical Center part of, is we are collecting data on all these patients who presented with ST elevation and how we manage them and what was the outcome. And if there's any collateral damage such as increasing the infection in the staff and so forth, which is, I think so far there's a 200 center involved in the US, and we're going to include close to 500 patients, which is going to be presented next month at a national conference as a late breaking trial. With that, I would like to end with a few messages for physicians and other specialty primary care referring physician as well as patients. There is very little we know and too much to learn about COVID-19. Cardiovascular disease is still the #1 killer in the United States, and patients should not neglect symptoms such as chest pain, shortness of breath, indigestion, especially in women, swelling in the legs. This should be triggering you coming to the hospital to be checked, and COVID-19 should not risk for COVID-19 should not stop you, because heart disease might get to you before the COVID. Cardiovascular care at DMC is always available with best precaution implemented to prevent patient from being at risk for COVID-19 infection. With that, I would like to close the presentation for today. We'll be discussing a few questions with the speakers. And also, if you have any question, please use the Q&A box. Thank you for your attendance.
Thank you very much, Chadi. I appreciate your insights as always, and nicely detailed approach showing this should give our referring physicians and our patients solace in knowing that that hospital systems have rose to the occasion and have figured out ways to safely treat the patients with ongoing cardiovascular disease.
Absolutely. As you know, Dr. Zer, I mean, we have a significant drop of these patients coming to emergency department, and that raised a lot of public news, as a matter of fact, for these patients not showing up. Even GI bleed disappeared, not coming to the hospital. And that's, as I mentioned, there is a lot of hypotheses that just a fear of coming to the hospital because they're going to get infected. And if they get infected, the chances of dying is high. But again, you illustrated that nicely of these patients coming late, and if they're going to require more advanced therapy such as ECMO or tracheostomy, and that's we want to prevent this from happening. And if these patients we can get them to them early, that would be better. All right, I think in terms of question, we got one question related to if the rapid PCR test can expedite care and in the hospital, and if that decrease the infection rate or at least increase the throughput in the patient coming to the hospital. What do you think, Dr. Zer?
Well, I mean, we've done very well in testing our patients before cath lab procedures and before surgical procedures, to the point where we know, and Yusuke very nicely delineated that the fact that despite, in providing ongoing care, we only had a few patients that ended up, testing positive. None of them died, and and that was early on in the pandemic. And so I think now we have safeguards. We have adequate testing, and our ORs and our cath labs are safeguarded against spread to both other patients and to our staff.
Absolutely. So as you mentioned, Dr. Zer, is all these patients coming for elective procedure are getting tested. It's, as a matter of fact, it's required to have these tests on file before the patient gets boarded to prevent infection. As a matter of fact, also we split our cath lab in the heart hospital at DMC into inpatient and outpatient. So every patient that is completely confirmed to be negative has a different entrance, had a different cath lab rooms, and also has a different exit. So there's no interaction with the inpatient if there's any suspicion of these patients coming to the lab. Especially they don't interact with the elective, that is more cold cases compared to the more active and urgent cases. That is not ruled out yet. All right, I think that's it for today. We have a question here. 65-year-old inferior STEMI patient, COVID positive, stabilized nicely after RCA stent. Patient also has 50% distal left main. How to proceed? So again, Dr. Zer is a 65-year-old inferior STEMI, COVID positive. They could treat him medically and eventually had an RCA stent, but also was found to have 50% distal left main disease.
Well, I would, you have already delineated out, the medical management of this patient. But I think this patient is also a surgical candidate as well because of the 50% lesion. But I think what we would prefer to manage this patient medically until the patient is free and clear of the virus, and then we would operate on them electively.
Absolutely.
And the cath lab has already fixed the right coronary, so there's a period of safety with a 50% left main that we can let the patient be managed medically until the patient needs to be done.
Absolutely. I think that's comes up. It's 10 after the hour. Thank you so much for all the attendees, and sorry for the technical issue at the beginning. We'll make sure this next time never happen. It's the first time here at the Detroit Heart Hospital. I would like to thank Elise Bennett for putting this together. Really, she put a lot of work and effort, and for our KP, our AV, and for kind of helping us with this project as well. Which is the goal number one, is to have increased knowledge about the disease and also how to manage heart disease during COVID era, and how is the impact of this infection virus on heart health in general, and what help we can offer these patients and the community. Thank you for all the attendees, and Dr. Zara and Terasaki for your time and your presentation, and hope you can join us again soon in the future. I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.